আসসালামু আলাইকুম, আমি শুভ বলছি মেলবোর্ন থেকে। ক্লাস কি শুরু হয় নাই? আমাকে কি শুনতে পাচ্ছেন আপনারা?
জি স্যার, আপনাকে শুনতে পাচ্ছি।
ক্লাস কি শুরু হয়নি?
না স্যার।
কেন, প্রবলেম কি হচ্ছে? প্রবলেম হচ্ছে কোনো?
জানি না
তা তো
স্যার।
বলতে পারছি না।
আর প্রথমে লিংক ওপেন হচ্ছিল না, পরে
না,
লিংক
এখন তো
কালেক্ট করতে
লিংক
পারলাম।
হয়েছে।
ঢোকার
আচ্ছা,
পরে
আমি
ঢোকার
দেখি।
পরে তো স্যার ক্লাস দেখতেছি না।
আচ্ছা, আমি ফ্যাকাল্টিকে ফোন করি। ইটস ওকে, আপনারা ওয়েট করেন। এই নাজমুল, তুমি কি অনলাইনে আছো?
আমরা সবাই রেডি আছি আমাদের ম্যাটেরিয়াল নিয়ে, ইনশাআল্লাহ।
হ্যাঁ, তাহলে শুরু করে দাও। অথবা তাহলে এমনি ইনফরমালি কথাবার্তা বলতে থাকো, না এটা সবাই কনফিউজ হয়ে যাচ্ছে যে হয়তো কি ক্লাস হচ্ছে না নাকি। ওকে ওকে, থ্যাংক ইউ ওভার টু ইউ।
আমি স্ক্রিনটা শেয়ার করতে যাচ্ছি, আপনারা কি দেখতে পারেন আমার স্ক্রিনটা?
দেখা যাচ্ছে।
জি স্যার, এসেছে স্যার, এসেছে।
হ্যাঁ ডক্টর নাজমুল, ওয়েলকাম। আসলে আমি একটু লেট হয়ে গেছে তোমার এখানে ঢুকতে। সবকিছু ঠিক আছে তো? নাজমুল, কি শুনছো নাকি আমাদেরকে?
টুডে কি আপনারা শুনতে পাচ্ছেন?
হ্যাঁ, শোনা যাচ্ছে। আপনারা সবাই শুনছেন?
শোনা
জি
যাচ্ছে।
স্যার। জি স্যার।
হ্যাঁ, না ঠিক আছে, শোনা যাচ্ছে নাজমুল, থ্যাংক ইউ। আমাকে মনে শুনছে না, না?
জি স্যার, শুনতে পাচ্ছি।
ঠিক আছে, থ্যাংক ইউ প্লিজ।
আচ্ছা, হ্যাঁ। তো আচ্ছা, তো আরো কি আমরা কিছুক্ষণ ওয়েট করবো আরো অ্যাটেন্ডের জন্য, নাকি আমরা শুরু করতে পারবো, কি মনে হয়?
নাজমুল, আমরা শুরু করে দেই। হ্যাঁ, থ্যাংক ইউ। নাজমুল মনে হয় আমাদেরকে শুনছে না।
হ্যাঁ, না, আমি শুনতে পারতেছি। আপনারা কি, আমি তাহলে শুরু করি না?
হ্যাঁ, প্লিজ শুরু করুন।
আচ্ছা, তো আমাদের যে আজকে যে আমাদের যে টপিকস, সেটা আমরা সবাই অবগত আছি, যে অ্যাপ্রোচ টু স্লিপ ডিসঅর্ডার ইন প্রাইমারি কেয়ার। তো আমার ওন ইন্ট্রোডাকশন আমি দিচ্ছি। আমি নাজমুল হক, জেনারেল প্র্যাকটিশনার্স, বাট আমি ফ্যামিলি ফিজিশিয়ান হিসেবে পরিচয় দিতে পছন্দ করি, কারণ জেনারেল প্র্যাকটিশনার্স এন্ড ফ্যামিলি ফিজিশিয়ানের মধ্যে কিছু ডিফারেন্স আছে, যেটা হয়তো আপনারা অন দ্য ওয়েতে ইলাবোরেটলি জানতে পারবেন। তো the sleep issue বা sleep disorder, it's a pandemic all over the world now, everywhere, including Bangladesh. So it's a huge issue. Sleep ইয়াতে যাওয়ার আগে আমরা যেহেতু আমরা প্রাইমারি ফিজিশিয়ান, আমাদের ইন ডেপথ ফিজিওলজি বা ইয়াতে যাওয়ার দরকার নাই, কিন্তু তারপরে বেসিক একটু আমরা টাচ করি, যেটা আমরা ফিজিওলজিতে অলরেডি আমরা এটা করেছিলাম। তো আমরা দেখাচ্ছি যে এই যে স্টেজ অফ নর্মাল স্লিপ সাইকেলে যে আমরা অ্যাওয়েক আছি, তারপরে আপনার স্টেজ 1, স্টেজ 2 আর স্টেজ 3 ডিপ স্লিপ। তারপরে আবার মাঝে আমরা পাচ্ছি যে আপনার র্যাপিড আই মুভমেন্ট, আবার এটা আবার রিকার করতেছে সিমিলার ওয়েতে র্যাপিড আই মুভমেন্ট। তো 8 আওয়ার স্লিপে আমরা অল টুগেদার অ্যারাউন্ড 4 সাইকেল আমরা পাই। তো আগে কিছুদিন আগ পর্যন্ত এটা স্টেজ 4 পর্যন্ত ছিল, এখন এটা স্টেজ 3 করা হয়েছে, এবং the classification was done depending on the pattern of waves, the brain waves. তো এটার ক্লিনিক্যাল সিগনিফিকেন্সটা আমি একটু টাচ করতে চাই, নট ইন ডিটেলস। যে স্টেজ 1 যেটা আমরা দেখছিলাম, যেটা it was just we are drifting to sleep, we are still awake. Stage 2 তে we are fully asleep and it's difficult to awake, but the important thing is that rapid burst of brain activity in stage 2 indicates that brain is organizing and storing the memories in stage 2. Stage 3, if we look at it, then it's a very really the deepest sleep we are having, and the importance of it, that it is essential for the restoring the body, the repairing the body, and refreshing with the refreshness which we enjoy in the morning. And it is important in another aspect as well, that for the memory and creativity is very important for the proper deep sleep. That means the non-rapid eye movement, stage 3. এই স্টেজগুলোতে we observe the growth hormone, which is important for the repairing of the damaged cell, and it activates the immune system for fighting back for the next day. তারপরে আপনার র্যাপিড আই মুভমেন্ট, যে স্লিপটা, ওটার ইম্পর্টেন্স হলো যে এখানে যে ড্রিম, উই আর হ্যাভিং দ্য ড্রিমস, and important finding is that our body muscle becomes atonic, so that we don't respond according to the dream. Otherwise it will be a disaster, because if we respond depending on the dream, it can be dangerous sometimes. And this is important for the brain is restored and prepared for the next day. So this is the importance of different stages of our sleep. And if we don't get it, and if we don't get the proper sleeps, we can see what can happen, how many systems will be involved in a negative way. I would like to show this picture just for an interesting thing, because it will explain everything. Our civilization actually basically is, we went for agriculture around 10,000 years back. Before that, life was basically hunting and gathering type. And we can see on these pictures that this is the morning in the cave. People are getting ready. Midday or just coming from the cave, people are busy for hunting, for gaining the livelihood. And this is night. They are preparing the food and they'll be going to sleep. But we can't see any, unfortunately, TV. There is no iPod or there's no iPhone or anything. So basically, if we look at our body, our circadian system, then it is very important, the early morning sunlight, physical activities, and a proper sleep. These are the 3 most important things for our existence. So if we compare our modern life with this picture, it's quite evident we are in basically in deep trouble, in deep dilemma. So now I would like to go formally about the type of sleep disorders. It was done actually by the, according to the International Disease Classification. We can see that insomnia disorder is number 1. Then sleep-related breathing disorder. Then comes, this is it's a different subject because it's related to the ENT and very complex, but very important. We will not go detail in this, in the number 2. Number 3, central disorder of hypersomnolence. Number 4, circadian rhythm sleep-wake disorder. That is interesting. We'll go a bit on the aspect. Most of the time, it is not diagnosed. It's just, we can't catch it, but the patients, they suffer. Parasomnia, interesting, but not very common. Other sleep disorders, rare things, will not touch. Now, the number 1 is the important one, common one, insomnia disorder. And not every sleep sleep problem is not insomnia. It has got some diagnostic criteria. If we look at these 3 points, that will be quite evident. I summarize it in a short, simple way. that sleep initiation and maintaining the sleep properly up to the morning. This is a criteria of a good sleep. And then comes adequate opportunity and circumstances to sleep. We have to give the person, my patients, a proper environment, proper scenario, proper situation for sleep. And then number 3, daytime consequence. This is one of the important criteria of insomnia, that patients will feel sleepy. Tiredness is different, but patient will feel sleepy. So please try to remember these 3 important criteria of insomnia, that falling asleep and maintaining it all through, and then daytime, and then to give them opportunity, a proper environment. And number 3 is if it is a real insomnia, it will show some issues in the morning, the next day. But these are the few related things, like I think I sent some pre-reading materials about this, like sleep latency, sleep duration and frequency related to insomnia. Like when you go to bed, we just don't fall asleep. It takes time. Usually average 20 minutes is the ideal one, but it shouldn't be more than 30 minutes. That means we have got an issue, then problem with our sleep latency. Sleep duration, it varies person to person, minimum 6 hours. 6 to 8 hours, we say. Our frequency, if we have a sleep problem 3 nights per week, then it will be insomnia. And then there is a division of insomnia, acute insomnia, which happens due to some specific events. And if it is less than 3 months, then it's acute. If it goes like any other, most of the chronic conditions, more than 3 months, then we call them chronic insomnia. Before, there is some other classification, like primary insomnia was there, secondary insomnia. Primary insomnia means we don't have any definitive cause. We don't find anything. And the secondary insomnia, nowadays we don't tell. They say that rather we should say comorbid insomnia, which is related to some issues. And interestingly, they call it bidirectional relationship. Like my sleep is causing stress, but maybe it's other way around. My stress is causing sleep problems. So that's why we call it comorbid insomnia, bidirectional insomnia. It's a relationship. We are doing the family medicine. I would like to request, and maybe you are already gone through it, this important slide. I would like to know, are you familiar with this principle? Can you give me somebody a noise? Hello, can you hear me?
Yes, sir.
Yeah. So আপনার কি এই কনসেপ্টের ভিতর দিয়ে আপনাদের কি গেছেন এটাকে
Yes, sir.
So it is very important because this biopsychosocial are আপনার micro context and macro context. These are the very important tools for us, for the family physician. Any conditions, not even disease, even personal, in our personal life, we can put the things according to these components. Like, as for example, insomnia will be a very good case for going through, analyzing and managing it through this principle of family medicine. We look any condition, any disease, any issues through our physical, related to, it could be related to our physically, it could be psychologically or mentally, or it could be our surroundings socially. So if when you go through a bit details about the insomnia, we can see that it affects it can fall into one of the categories, or it can touch all of them, all of the three. So it's not only insomnia. As a family physician, you will be able to apply this principle in any condition. And micro context and macro context, I put it, the effect of insomnia or any conditions, how it affects personally to me or my family and my work, the society, community, country. So these will be applicable in insomnia as well. Now I would like to jump to a case study. Can one of us read this for me, please? Can I request Dr. Hoque Khatun for reading this for me, please? Is Dr. Hoque Khatun online?
Hello, কেউ রেসপন্স করেন ডক্টর রোকেয়া?
Sir, can I read it, sir? Dr. Hoque is not responding, or probably in.
Okay, maybe she has got some technical issues or some other issues. So let's go to Dr. Mubashara. Can you help us reading this case study?
Yes, sir. Assalamu alaikum.
So, please help us reading this case study.
I should recite this case study.
Yeah, please just recite it. Yeah.
A general practitioner, patient of mine, who is concerned about his daytime drowsiness and frequent yawning during patient consultation, which is quite embarrassing for him. He falls asleep during clinical meeting and other colleagues make fun of it, including sharing photos of his nap in social media. He is a healthy 57-year-old male with no chronic condition, with full of aspiration and joy in life. A sleep diary was provided, and on review, it was reflected his bedtime was 11 p.m. and spent on reading anything in bed, which is an elixir of his life. He falls asleep around 12 p.m. with a good sleep latency of 10 minutes. He wakes up at around 6:30 a.m. as his partner wakes up early for her prayer. He tries to fall asleep but fails to fall asleep again.
So thank you for reading, Dr. Hoque. It was a nice reading. Nice. So if we look at the case study, I put this case study, it's a real case study, a real patient, interestingly. And if we analyze this case study, do you think it will fall into in the insomnia? We can apply the three important criteria of insomnia. Like if we go back to the, where is it? Insomnia, like sleep initiation and maintenance problem. If we look at the case study, we can see the patient can fall asleep in 10 minutes. His sleep latency is very good and there is no disturbance. He can sleep all through, but he's waking up at 6:30 as his partner is waking up for the day. And then we can see the daytime consequence. He's feeling drowsy, sleepy during the daytime. So this is quite evident, daytime consequence. But do you think the patient is getting adequate opportunity and circumstances to sleep?
No, sir.
You're right, because if we look at it, maybe he needs, everybody's sleep duration is different. Maybe he needs an 8-hour sleep, but he's getting only 6.5 hours. So he's not getting proper sleep, but that is causing this problem. But by definition, we are not providing the adequate environment and circumstances for him. So that's why we cannot call this sleep issue, the sleep problem, as insomnia. This doesn't fulfill the criteria. So this is very important on that sense, because the management, when you'll make a management plan, it will be completely different lifestyle issues and the environment, creating a proper environment for him. Medication or other things has got no role. So is it all right? Did I explain it properly, or we need further elaboration? Okay.
Clear, sir. It's clear, sir.
It's clear, no? So then go back to again the classification. Circadian rhythm. Okay, no, sorry. Let me have a look. Case study 2. Again, the case study 2. Can one of us, Dr. Rifat, can you read? Can you please read it for me?
Yes, sir.
Yeah, please move
A
forward.
55-year-old housewife brought to me by her partner with the concern of her sleep pattern. She goes to bed around 11:30 p.m. and falls asleep by 12 p.m. She wakes up at the night quite frequently for checking her children, whatever they have arrived from work safely. She wakes up at 6 p.m. for her prayer and other house chores. She did not report any drowsiness or tiredness during the daytime. No chronic condition is identified with this patient. Her husband learned that proper amount of sleep is important for mental and physical well-being.
So husband is concerned with the partner about the amount of sleep she's getting, and she's waking up at night as well. But interestingly, if we look at it, that during the daytime, there is no issue, there is no problem, no complaining about drowsiness, sleepiness, or tiredness. So it doesn't fulfill the criteria of insomnia. And the patient is waking up a bit frequently at night. And if we look at the sleeping hour, that goes to bed around 11:30, and by 12 p.m. she's awake. So basically she's getting 6 hours sleeps. But a lot of us, we have got an idea, a lot of our patients has got an idea about the wrong idea about the duration of sleep. A lot of us, we think that we need 8 hours sleeps. And that creates a huge problem, because patients, they identify themselves as a patient of insomnia. But this is not right, because some people, 6 hours is quite enough for them. So in this case, the husband, we have to explain it to the husband that what is happening, that is acceptable. It is the problem of the husband's thinking process. So we need to correct it, because it can affect the family and everything. So this is the second case study for the insomnia. And then we're gonna move a bit forward. Sleep-related breathing disorder is a serious issue. That is, we call them sleep apnea, which cause significant drowsiness, tiredness during the daytime. But we have to ask specific questions about snoring and broken sleep. And then we have to refer the patients to sleep, to the ENT specialist or sleep physician, respiratory physician, for proper diagnosis and management. So we are not touching that area, we are leaving it. Then we are going back to another interesting one, the central disorder of hypersomnolence. The patients feel sleepy, drowsy, and there is some conditions which falls into this category. If we look at it here, narcolepsy, and then idiopathic hypersomnia, we don't find the cause. Then hypersomnia due to medical conditions, hypersomnia due to medications and substance abuse, hypersomnia related to psychiatric disorder, and this cause actually hypersomnolence during the daytime, and it can be mistaken on a different way. I would like to go for then we can read this case study again. Who is gonna put the hand this time? Sorry for this. can I request Dr. Leah?
Yes, sir. Thank you, sir.
Yeah, please.
A wealthy 59-year-old farmer in our village was legendary for his ability to sleep. He could fall asleep in any place in any time. Missing train and lunch were the norm for him. He is used to have uninterrupted sleep at night, basically dawn to dusk. No chronic condition, perfectly healthy. Still, he could not resist his sleep during the daytime. It turned him into a laughing stock in the community.
Okay, thank you for reading, Dr. Leah. And if we go back to the classification, we can see that he might fall, as we mentioned, that he is perfectly healthy. There is no physical conditions. He's not on any medications, and there's no psychiatric conditions or mental issues. So most probably he might fall into narcolepsy because it's a long-standing conditions. Narcolepsy is not very common, actually. As a general physician, if we suspect, we can send the patients for the proper diagnosis by sleep study and some blood tests. So we are not going to in details because the prevalence is low in general populations, and it is not our field to deal. So then we go to another classification. This is interesting. The circadian rhythm sleep-wake disorder. Before that, I would like to go before we go in detail, I would like to go for a case study again. This time, Dr. Divakar, can you help us?
Yes, sir.
Please.
21-year-old university student was brought to me by his mother with the issue of his sleep pattern. He goes to sleep after midnight and wakes up late in the morning, which is affecting his study. It is a significant way. The tutors are concerned about his alertness in life and the class and occasional drowsiness. On inquiry, he mentioned his genuine effort of going to bed early with optimum sleep environment, but in vain. He tried repeatedly, but without any success on falling asleep in time. He does not have any chronic condition, no sign of depression and anxiety.
Thank you, Dr. Divakar. If we look at the case study here, we can find similar things a lot in modern day, like especially among the teenagers. They've got a habit of how do you call it, going to bed a bit late and waking up in the morning. So that is an intentional life issue. But in this case, if we look at it, this patient, which is a real patient of mine, he is maintaining good sleep hygiene, no psychological things. He tries his best going back to bed properly and waking up in the morning, but he can't. So it's not his bad intention or bad poor sleep hygiene. If we look at it here, that in a circadian rhythm that maintains actually our sleep and wake cycle, sleep and wake rhythm. So if it goes this kind of things for more than 3 months, then it is a issue, it is a disease. And then, you have got the case I have shown, we call them delayed sleep-wake phase, because they are falling asleep a bit delayed. So, and the opposite is advanced sleep-wake phase. And then comes similar things which affects the circadian rhythm, shift workers. And nowadays, a lot of us, we are traveling internationally, crossing the time zones, jet lag disorder. So these are the conditions, they affect our circadian rhythm, causing sleep disturbance. And sometimes it needs proper management and treatment. Like for this patient, the case study Dr. Divakar you have gone through, he is suffering from delayed sleep-wake phase disorder. It is an unintentional condition for that boy. So this is the issue of the circadian rhythm. The thing is that he's going bed late and waking up late. It is disturbing his sleep. It will disturb for a lot of people's their work and commitments. So we can't leave it as it is. We need to address that one. The opposite one, the percentage is low, like advanced sleep. They can't keep their eye open. They go to bed early and they wake up early in the morning. Even if they want to try to sleep more, they can't. But unfortunately, it doesn't affect the social life, doesn't affect the study or business or work, but the delayed sleep-wake phase, it affects. You'll find patients like this. Especially it's very common among the teenager, but most of them definitely is the lifestyle problem. And so if we look at it here, the management-wise, it's here. We can start with a simple one, the jet lag one. So you'll find patients, those who will be traveling and they had issues with sleep, and they might come to you for the solution about the jet lag. So what we can do for them. So it's a issue of time, what do you call it, crossing the time zones. Like if somebody is in Bangladesh and traveling to Australia, they are traveling east way. That means when they will reach in Australia, next day, it will be, what do you call it? It will be in the afternoon, but maybe in his body, the circadian rhythm, according to the Bangladesh, this is still morning. His body wants to sleep, but the environment is different. So we need to help this person. And the simple way is try to going to sleep according to the time zone. I know it's difficult. In that case, actually, we use melatonin as a help. That can be very helpful. And then same as the shift worker, it's a big issue because unfortunately the shift worker, they've got no control on their sleep, and it can have a serious effect later on in their life. Melatonin can be some role, but unfortunately there is no great help because this is a situation they've got no control on it. So then comes the which we talk about the case study, advanced sleep disorder. Like in that case, we have to do the similar. We can use the melatonin here very interestingly. About 3 hours, 2 to 3 hours before the desired time, and that might help us. As well as getting the morning sun that stimulates the melatonin process can be helpful. And then the advanced sleep, we don't need to worry about it. Do you have got any question about the jet lag and other things, please?
Sir, shift worker disorder, I do as a medical officer in an industry. So I get a lot of case about this, sir. Please share your experience about this, sir.
Most of the patients we see in a shift work, if we can provide a proper environment their cycle, they can settle it in that area, even though it's not a healthy practice. But the melatonin that can help artificially to giving a signal to their brain that because the melatonin is increased in darkness. So if they keep a nice, proper, dark, cool room and get some melatonin, which is quite safe, few hours before the desired bedtime, that might be helpful for them. That might be helpful. This is the one of the things. And interestingly, as I mentioned, that they make if they do it properly in a proper environment, they can break down their shift sleep-wake cycle properly. But in the long run, that's not definitely it's not a healthy way to go.
Thank you, sir.
Yeah, thank you. Then comes another interesting, the sleep-related movements disorder. I would like to know your experience about this condition, the restless leg syndrome or periodic limb movement disorder. Are you getting patients on this category?
স্যার আসসালামু আলাইকুম।
ওয়ালাইকুম আসসালাম।
স্যার ডক্টর মামুন আমি স্যার।
ওকে।
আরএলএসটা স্যার আমাদের প্র্যাকটিসে ডে টু ডে লাইফে বেশ পেশেন্ট পাওয়া যায় স্যার। আরএলএস এটা খুবই কমন স্যার, বাংলাদেশে এটা খুবই কমন স্যার। আমরা যারা জিপি করি তারা এই পেশেন্ট আরএলএস এর পেশেন্ট খুব পেয়ে থাকি, রেস্টলেস লেগ সিনড্রোমের পেশেন্ট স্যার খুব পেয়ে থাকি। তাদের কমপ্লেইন এরকমই থাকে যে তারা দিনে ভালো থাকে হাঁটাচলা করলে, বাট সন্ধ্যার পর থেকে বা রাতে যখন ঘুমাতে যাবে তখন স্যার একটু অস্থিরতা হয়, কোনো কিছু দিয়ে চেপে ধরলে ভালো লাগে বা কোনো কিছু দিয়ে পাটা আটকে ধরলে ভালো লাগে বা একটু হাঁটাচলা করলে বা একটু শেক টেক দিলে। তো এটা স্যার মোস্ট কমন আর কি আমাদের জিপি ডে টু ডে লাইফে স্যার, এটা খুবই কমন একটা কেস স্যার। আরএলএসটা খুব পাওয়া যায় এদিকে স্যার।
Thank you for the input, because I had a different idea. So at least the general practitioners, they are picking it up and treating. That's a very reassuring for us. One thing we have to keep it in mind, that this restless leg syndrome and periodic limb movements, it is into iron deficiency relationship আছে। এটা one of the single most important investigations, because সাবস্টেন্সিয়া নাইগ্রা যেটা ব্রেনে আপনার ডোপামিন গুলি প্রডিউস করে, ওখানে এই আয়রন মলিকুলার গুলি দরকার হয়। So if we don't have enough iron in the body, then that can be one of the cause. But most of the time we don't find cause, but that is very important for us to exclude. Huh? And we know the treatment. So I think most commonly we are using the pramipexole. I use it mostly. And then other things also, if it doesn't work very well, we can try the Lyrica, pregabalin or gabapentin. And as the condition is related with the dopamine issue, very rarely some of the specialists, they use the Parkinson's medications, which is also a manifestation of low dopamine production. And this is another opposite things, the periodic low limb movements. That is interesting in that sense. The patient can fall asleep, but they are moving that much. They don't realize it, but their partner, they suffer basically. They are kicking, touching, pulling, pushing, and then the patient, they don't realize it, but their sleep quality, quality becomes badly compromised. So next day, they suffer from the sleep deprivation issues. It's not very common, definitely, like restless leg syndrome. The partner, usually the partner, they raise the issue about the periodic limb movement. It has got a similar importance, even though patients, they don't recognize. In restless leg syndrome, they will come forward and the presentation will direct us about towards the diagnosis. And at the same time also, we have to exclude the other things other than iron study, the kidney problem, diabetes, peripheral neuropathy, can also, and even simple cramp can be mimicking like restless leg syndrome, but the treatment will be different. Then comes parasomnias, which is interesting in the movies and things, but in real life, actually, we have got, but it's not a big issue, like sleepwalking and sleep terror and nightmare. This is not uncommon, but what should I tell that it happens basically non-rapid eye movement conditions. The problem is they can do the sleepwalking, sleep terror, but interestingly, they don't hurt themselves that much. For some reason, they can navigate the room things properly, but still we have to be a bit careful about arranging the bedroom for the safety of the patient. But another uncommon, the REM sleep disorder, the parasomnia component, that when our muscles are supposed to be going into atonia, completely atonia, so that we don't respond according to our dream. When it doesn't happen, then it's a big issue, because in that case, the patients can become violent and do so many things even, and they basically put them into danger themselves. They're not harming only people around, but harming themselves as well. That needs proper treatment by medications, especially like clonazepam. And if it happens, then we have to, it indicates some early stage of some neurological conditions like Parkinson's and Lewy body dementia. So that needs proper referral. As a family physician, we have to provide something tangible that to the patient, that we can just talk. We have to give something, and for the proper analysis of the sleep issues, I have placed one sleep diary. আপনারা কি এটাতে did you find time to go through it? We can give it to the patient. I know we don't have enough time going through the patients in details, but at least we can give it to the patient, and they can come back after 1 week or after some time with filling up the columns and things. Like they will do it in 2 ways, like before going to bed, they will put the things like number of caffeinated drinks they had. Alcohol is not an issue in our country. And during the daytime, any nap time, any sleep, exercise, and most importantly, how sleepy they were during the daytime. Was it a mild? It was a severe? This is also important. And then comes another one, filling out just after waking up. It's not a big task. Just for 1 week, it will give us an idea, like at what time they went to bed and when did they wake up, and that will give us an idea about the duration of the sleep. And number of waking up also important. That could be due to physical or other issues as well. And then the sleep latency, how long it took to fall asleep. If it is more than 30 minutes, that's the issue. And the medication has got important role as well. Like some of the medications, especially anti-inflammatories and the steroid like prednisolone, have got a serious, and as well as the SSRI has got significant issue of sleep disturbance. So by this way, we can actually identify the issues, and then patient can see themselves that where are the issues, and so that they can take action accordingly. So as a family physician, this is our role to guide them. And this is a practical way. If we use it, then amazingly you'll find a lot of interesting things. And we can just point it out and patient will implement it. That will be a big help. So not only the medications in real life, in insomnia or sleep disturbance, we can find the cause ourselves. And if they address, they can make a good night's sleep. So I know it's difficult, but please try time to time this sleep diary and go through it yourself at the end of the day, and the patient can come back again, and then we can discuss. So this will be a strong tool as a family physician for us. This is a picture, I put it intentionally. We can see the difference. Here, they are sleeping nicely, and here we can see he is struggling for sleep. The difference is, as I have shown in the beginning, a picture, the caveman picture. They are waking up in the morning, working the whole day, and they don't have any complex issues in life, and what do you call it, long-term plan. So they're sleeping even in a peculiar environment, but here we can see the issues. So this is the, what should I call it, the curse of our civilization. How much, and we have got very little control on it, but at least we can identify some of them. Now we will come to some sleep management program. As a general physician, as a family physician, we will definitely look at the sleep hygiene. This is very important. As we pointed out before, the caffeine, the coffee or tea, usually you advise that at least 3-4 hours before bedtime, we should stop taking. And maintaining a regular bedtime and waking up time is very, very important, very, very important. We shouldn't try to compensate our yesterday's sleep by extending our morning sleep or going bed too early. That is counterproductive because it breaks the circadian rhythms and body clock, and it creates a problem. So advising patients, please maintain the regular bedtime is very, very important. Another thing is that nowadays a lot of people, we go to gym at night and at the end of the day, which is not actually very healthy choice. Actually, exercise, human body was made for exercise or physical work during the daytime only. At night, we have to give a proper relaxation physically and mentally as well for the proper sleep. And for the bedroom, actually, it should be basically for the sleep. It shouldn't be the lounge room, like nowadays, a lot of electronic devices are there, like iPad or even a smartphone. We know it emits a blue light, which stimulates our brain and can cause a problem in our sleep. So what about your idea about, what do you call it, reinforcing the sleep hygiene among your patients? How do you do it? Can you share it? Hello, are we still, can you hear me?
হ্যাঁ, আমরা শুনছি। এই পার্টিসিপেন্টসরা কথা বলেন, কথা বলেন আপনারা কেউ একজন।
It's okay. Then this is important. We shouldn't, it's a simple things, but we should mention it to the patient because even the patient knows, but when their general practitioners or family physician talks about simple things, they take it seriously. So please don't neglect it, reinforce it. Is very important. And then we'll go to the next plot. As we mentioned before, that maintaining a strict sleep and wake time is very important. We have to find out actually every individual's requirement of the sleep duration is important. We have to find it out first, and then we can make a plan about the sleep time and things. And another thing is that, like, if I can't sleep like in my allocated time, we shouldn't go for a big nap next day. We should, maybe you can go for a very short one, because if we don't do it, that will be helpful for us to fall asleep next night, and we can go establish the pattern again. This is another important things, like avoid naps during the daytime, which we have already talked. Only go to bed when sleepy, and things, return to bed when sleepy. But interestingly, one important things I would like to mention, we mentioned that we have to go to bed a proper exact time, waking up exact time, but there's some exception. If we look at it in some situation, like when people go to bedroom, they feel scared when they see the bed. Oh my God, I'll not be able to sleep again tonight. And like a clock in the bedside clock or wall clock, it becomes a terrifying things for them. Because when they see the bed and the clock, first thing strikes into their head that, oh God, it's going to happen again tonight. So in that kind of scenario, actually we call them conditioning. It becomes conditioned in the brain. So we have to break it down. In that case, actually, we should go to bed only when we feel sleepy, other than tossing and turning in the bed. I'm talking about some small portion of the patients. Most of the time we have to maintain the bedtime and waking up time, but for some patients, we have to make some exceptions. They should go to bed when they will feel sleepy, and if you can't fall asleep, they should come out of the bed, come out of the room, doing something different. When they'll feel sleepy, they'll go back again. So that way, by this way, actually, we can remove their fear of anxiety about sleep, because stress and anxiety compounded the insomnia. So because their bed, their environment, and some specific things precipitate stress and anxiety, and they can't fall asleep. So that's why we have to take them out from that scenario. Then comes the pharmacological treatment. Interestingly, until now, most of the time we use basically pharmacological agents like benzodiazepines, and nowadays some medications working on the receptor of the benzodiazepines like zolpidem and zopiclone. Interestingly, benzodiazepine, when we use pharmacologically, they are saying that if we use it continuously more than 6 weeks, 4 to 6 weeks, the receptor changes actually, and it is not supposed to work for sleep. It will give us drowsiness next day or this and that, but theoretically it shouldn't work. So it's very interesting, because if it is the case, we are giving patients year after year the same benzodiazepines or related medications. So we are doubtful how effective pharmacologically and how much is the placebo effect. Unfortunately, the side effect is real, like drowsiness and imbalance. It can cause fall in elderly and can cause problem. So if somebody has got a long-term use of benzodiazepine, we should think about rehabilitating those patients, gradual withdrawal. We can offer it by alternative medications. Like if the patient has got an underlying anxiety or depression, we can give proper medications, taking slowly off the benzodiazepines. And if we actually do the rehabilitation process, usually we make it half every one month, the doses, and then gradually we go out of it. Another new medications, I think, which we can find in Bangladesh, like Sobutol. It works in a newly discovered, what do you call it, receptor, orexin, which is actually keep us awake, give us the alertness. So newer medications is working on this receptor, blocking it and decreasing our alertness and helps our sleep. That helps the sleep latency, maintain the sleep well. And it has got less dependency and side effect than the benzodiazepines. But still, long-term use any medications can develop the tolerance. Melatonin is a relatively newer player in our block, but we shouldn't think melatonin using in every patient. It has got some specific criteria, like melatonin produced in the pituitary, and with the aging process, the production goes down. Anxiety, stress, depression decreases it. Some of the medications decreases it. If our body is not exposed to the sunshine, the production goes down. So we have to find out the appropriate case. Like basically, people with the age of 55, 60 and above, naturally their melatonin level is low. So these medications can be helpful for them. Nowadays, we are using in the pediatric patients as well, but still the research, the comparative study is not out completely, how effective it should be and how long we should use it. Melatonin, if we use it properly, correctly, that might be helpful for some patients, including the jet lag and shift worker as well. Pure melatonin, it breaks down very fast in the first cycle. It basically in 1 hour, it goes to the peak and it goes down. So we need a modified release or slow release. And usually it peaks in 3 hours time, it goes, blood level goes at the peak. So we advise to take it 2 hours before going to bed, and that can be helpful. That can be helpful, but still, interestingly, it can cause similar like benzodiazepine, some drowsiness again during the daytime. So you have to be very careful. Some common side effect is like a headache, muscle pain, body pain can happen with melatonin. Off the shelf, we are using amitriptyline, then quetiapine, antihistamine, we use, but which is not textbook recognized one. We use it on our personal choice. But one thing again, benzodiazepine has got a role of management of insomnia. As we go back to the initial classification of insomnia, like acute insomnia, which is related some stressful life events or something very specific incident, that can be, in that case, they are the good, what do you call it, good candidate for the benzodiazepines. But we have to make an agreement with the patients. Look, we are gonna use it for 4 weeks, 4.5 weeks maximum, not more than that. By this time, we have to find out the alternative things that could be a counseling, psychotherapy, or other medications. But benzodiazepine will make an agreement with our patients that we are gonna use, we are not going to use it more than 4 to 6 weeks. And by this way, at least the patient will be aware from the very beginning that this is not an indefinite management. So by the by, this is an interesting movie, Insomnia. I think it has shown how it affects the reflexes and thinking process. It's a 2002 movie by Al Pacino and Robin Williams, very famous movie. If you find time, you can go through it. What else we have left now today? We have gone through the treatment. This is the picture actually I took. I was traveling to Queensland and I saw this gentleman is sleeping under the tree. He didn't need a good quality pillow, good mattress. He can sleep. So because his life is very simple. So I think it is a line from our poet Rabindranath, ফিরিয়ে দাও হে অরণ্য লও এ নগর লও যত লৌহ লুস্ট্র কাষ্ঠ প্রস্তর হে নবসভ্যতা. So this is my presentation. Now we can we can open the floor and then we can talk. We can share our experience. We learn from each other. So please come forward.
আসসালামু আলাইকুম স্যার, আমি ডাক্তার নজরুল। আমি জানতে চাই স্যার, আমাদের প্র্যাকটিসের চেম্বারে অনেক সময় অনেক রোগী আসে যে বলে যে অনেক ঘুমের ওষুধ খাইছি, এটা ঘুম হচ্ছে না, কিন্তু ওই নিদ্রা কুসুম তেল দিয়েছি মাথায় অথবা অন্য তেলের অয়েলের কথা বলে স্কাল্পে। তো এই যে ট্রপিক্যাল তেল বা অয়েল বা আয়ুর্বেদিক এই সমস্ত ট্রপিক্যাল অয়েল গুলার কোনো ভূমিকা আছে এখানে স্লিপিং এর ক্ষেত্রে? আর দ্বিতীয় প্রশ্ন হচ্ছে যে স্যার, এই রেস্টলেস লেগ সিনড্রোমে ক্যালসিয়াম বা ভিটামিন B12 এর কোনো ভূমিকা আছে কিনা?
No, thank you. It's an interesting question. আপনি যেটা বলছেন যে topical application of the oil, এটা in our experience when we were small in Bangladesh, in village and everywhere, it was a very common practice. Like if you are going through stress, anxiety, বলতো যে মাথা গরম হয়ে গেছে তখন তেল দেওয়া হইতো, and it worked. But even though scientifically we can explain it, but definitely it has got maybe a placebo effect, but it's a good effect, good acceptable placebo effect, because it's not harmful, it's not causing any problem. So why not? We will accept it. And if we look at the interesting fact about placebo, like 30 to 35% people, they are placebo reactor. So even if you have got a severe headache, if we give a sugar pill out of 100, 30 people will respond. Their pain will be gone. And it's a huge number percentage-wise, no? Almost 1/3. So this is, we can explain physiologically as a placebo effect. So, but scientifically, definitely, I don't think that, what do you call it? We can explain it scientifically, but definitely if it works, why not? You should go for that. It's much better than any medications and things. And the second questions, we have mentioned that the calcium and vitamin B12, the role of this in the, what do you call it? The restless leg syndrome. No, the literature and journal, we didn't find anything like that. It works, actually it happens due to the issues on the calcium channel in the nerves, the muscles, definitely. But supplementation of calcium is not going to helpful because it doesn't work on that way. And vitamin B12, yes, if somebody has got a peripheral neuropathy, undiagnosed or unknown, that might be helpful, but not as a regular part of treatment regime about the restless leg syndrome.
Yes, thank you. Assalamu alaikum.
নাজমুল, একটু অ্যাড করবো, শুভ বলছি।
Yes, please move forward.
হ্যাঁ, যেটা আমার মনে হচ্ছে যে ডাক্তার সাহেব, ডক্টর নজরুল যেটা বললেন আর কি, ক্যালসিয়ামের কথা, আমাদের ছোটবেলায় আমরা যেটা দেখেছি যে ওই টিটানির যে ব্যাপারটা, যেটার জন্য মাসল টুইচিং হয়, এটা অনেকে সম্ভবত রেস্টলেস লেগ সিনড্রোমের সাথে মানে লেভেলে, প্রাইমারি কেয়ার লেভেলে কনফিউশন হয়ে যেতে পারে আর কি। হ্যাঁ, তো আমাদের ছোটবেলায় মানে আমরা যখন মেডিকেল কলেজে পড়েছি তখন দেখেছি যে টিটানির কিছু কেস আমরা পেতাম। তো আমার মনে হয় কনফিউশন লাগলে ক্যালসিয়াম দেখে নিতে পারে, ক্যালসিয়াম লেভেলটা দেখে নিতে পারে আর কি। কিন্তু এটাকে রেস্টলেস লেগ সিনড্রোমের সাথে কনফিউজড কোনো ক্ষেত্রে করে ফেলতে পারেন কোনো প্র্যাকটিশনার, এটা একটা বিষয়। আর এই নিদ্রা কুসুম তেল বা যে তেলটার কথা বলা হলো, আমার মনে হয় এখানে আরেকটা জিনিস ইম্পর্টেন্ট, যে ওই যে আমরা বলতাম না যে বিশ্বাসে মিলায় বস্তু তর্কে বহুদূর, যে সে এই জিনিসটার উপর আস্থা করছে, এটার মধ্যে একটা সাইকোলজিক্যাল ইফেক্ট আছে কিন্তু, যে দেখেছে যে পাশের বাড়ির দিদি বা মাসিমা বা আপা নিদ্রা কুসুম তেল দিয়ে ঘুমাচ্ছেন, তো এটাতে হয়তো ঘুম হবে, আমার মাথা ঠান্ডা হবে, হ্যাঁ, আমার বায়ু চড়া আছে, মাথা ঠান্ডা হবে, এটা একটা সাইকোলজিক্যাল ইমপ্যাক্ট, পজিটিভ ইমপ্যাক্ট আছে আর কি, অন টপ অফ দি প্লাসিবো ইফেক্ট। এটা আমার ধারণা। থ্যাংক ইউ।
আমাদের
ডক্টর
যেহেতু
নাজমুল,
সময় কম, আপনি যেটা বলছেন যে
ডক্টর
মানে
নাজমুল, আমি
বাংলাদেশ,
একটু
প্লিজ
ডক্টর
প্লিজ
নাজমুল,
প্লিজ,
এই আমি সবার শেষে বলতে চাইছিলাম, যেহেতু ডক্টর শুভ বলছে এর জন্য এটার সাথে একটু অ্যাড করতে চাচ্ছি। জবা জবা কুসুম তেল, এটার ব্যাপারে আমার একটা এক্সপ্লেনেশন আছে। এটা হলো যে এটাতে আহ, এই তেলটা কারা ইউজ করে, মেইনলি যারা আপনার 40 অ্যাবাভ বা 45 মহিলারা মেইনলি ইউজ করে। তো ওরা কিন্তু তাদের ফিজিওলজিক্যালি তারা একটা স্টেজে চলে যায় যখন হট ফ্লাশ হয়, ইয়া হয়, এইসব কারণ করা হয়, এবং যে পেরিফেরাল নিউরোপ্যাথি ডেভেলপ করে। ওইটার মধ্যে কিন্তু কর্পূর থাকে, যেটা খুব ঠান্ডা একটা ফিলিংস দেয়। ঠান্ডা ফিলিংসটা এখানে তাদের হট ফ্লাশ এবং পেরিফেরাল নিউরোপ্যাথিতে এখানে সুদিং ইফেক্ট করে। এটা ইমিডিয়েটলি তাদের একটা ফিলিংস দেয়, হ্যাঁ আমার মাথাটা ঠান্ডা হয়েছে, আমি এখন ঘুমাইতে পারবো। এই যে ডক্টর শুভ বা আপনি যে কথাটা বললেন যে আমাদের একটা সাইকোলজিক্যাল ইফেক্ট হচ্ছে, এটার সাথে এই কর্পূরের ব্যাপারটা কিন্তু একটা ইম্পর্টেন্ট ইস্যু। কারণ প্রত্যেকটা ব্যাপারের সাথে কিন্তু ফিজিওলজিক্যাল কিছু জিনিস না থাকলে আসলে এটা ওইভাবে কাজ করে না। আমার মনে হয় এখানে ওই যে ঠান্ডা ফিলিংসটা দিচ্ছে কর্পূর, সেটা একটা ইফেক্ট হিসেবে কাজ করে।
You are completely right.
Sure.
Completely right. That effect helps them to, at least they've got the faith now something is happening, and that window period they can go back to sleep using that window period. Maybe it will not last hour after hour, but even if it lasts half an hour, that's enough for them going back to sleep. No, you're right, Dr. Kabir. So we didn't talk a lot. Unfortunately, it's a vast subject. Like as I mentioned. As a family physician, we have to always keep it in our head, biopsychosocial. Please explore the patient physically, like an elderly man have got a joint pain, has got a enlarged prostate, going to toilet quite frequently. So we have to look those things as a sleep disturbance. It's not insomnia, but definitely sleep disturbance. Those and the medications. So bio aspect we have to explore. Then psycho, in a modern day time, who is not suffering from stress, who is not suffering from anxiety and the depression. I mean, we can't fulfill our expectation, we can't fulfill our family needs. So in our time, our parents, they've got a fixed life. I think they didn't have that much expectation. The stress and work pattern was completely different. Then in one generation, things have changed. So in Bangladesh, you are the fighter, actually. You are the front soldier, as general practitioners we are. So we have to please look at those things, which has got a direct effect on the sleep, no? The anxiety and depression, one of the very common symptoms. So we have to explore it that in detail. Then comes the social aspect, noise, sound, and other things also affect, which has unfortunately we've got very little we can offer. So our lecture is a very just simply guideline. It's a vast things. We will be our own teacher by going through reading it and expanding it. But please always think about the biopsychosocial and micro context and macro context, how it affecting us, my family, my work, my community, everything. And by this way, we'll be able to. We might not be able to solve the problem. At least we can identify the issues and put it to the patients, and they will be very happy when we can identify the things. Treatment management, yes, we will offer, but not necessarily it will solve the problem always. Thank you. So let's talk about other things. If you have got any questions or anything.
আসসালামু আলাইকুম স্যার, আমি ডক্টর আসিফ চিটং থেকে বলছি। স্যার এখন তো নিউ একটা ড্রাগস ওই মেলাটোনিন ট্যাবলেট 3 মিলিগ্রাম ফিল ফ্রেশ ইউজ করতে দেখেছি, এটা হাইস্ট কতদিন পর্যন্ত ইউজ করা যায় আর কোন টাইমে দিলে বেটার?
We can use it long time. I mean, only if we have got issues with the liver, especially because it's metabolism in the liver, and definitely any medication with the kidney function we have to look, but liver is an important thing. And if we are having other medications which induce the liver enzymes, you have to be very careful. And then in my lecture, I have mentioned that most of the preparation must be modified or slow release, because pure melatonin, it just lasts 1 hour, 1 and 2 hours, then it's gone. So we have to go for modified one, 2 milligram we can start, and it reaches blood level at in 3 hours time. So we'll adjust like at least 2 hours before going to bed. If we give, then it will be helpful. And we can increase the dose. A lot of people say on 5 milligram, even we can go further than that, even 10, but I think 5, most of the people, we can settle them with 5. 10 is also is okay, but as I mentioned, we'll be taking 5 milligram. And it's a interestingly, we can use it for a long time without creating any dependency, like benzodiazepine. So that's a good thing. But don't we shouldn't use it as a general measure of insomnia for every cases, because unfortunately that's not the case, because sleep insomnia, sleep disturbance, not always due to melatonin. Elderly, for the elderly people, they are good candidate.
Thank you, Dr. Nazmul. উনি যে প্রশ্নটা করছে, আসলে আমাদের দেশে আনফরচুনেটলি খুব বেশি মেলাটোনিন পাওয়া যায় না। ফিল্ড ফ্রেশটা 3 mg প্রিপারেশনে পাওয়া যাচ্ছে আমাদের এখানে। একটা ফিল্ড ফ্রেশ একটাই সম্ভবত এখন মার্কেটে আছে। তো ফিল্ড ফ্রেশটা ইজ ভেরি ইফেক্টিভ। আমি প্রচুর পেশেন্টকে, আপনি যেটা বলছেন যে ক্রাইটেরিয়া গুলো দেখে একটু এল্ডারলিদেরকে ইউজ করে দেখেছি, খুব ভালো কাজ করে। তো উনি যেটা আসলে জানতে চাচ্ছেন যে কতক্ষণ আগে, ডক্টর নাজমুল কিন্তু বারবার বলছে যে মিনিমাম 2 আওয়ার্স আগে এটাকে খেতে বলা হয়েছে। আমি স্পেসিফিক্যালি লিখে দেই 8টায়, যদি কেউ 11টায় শুতে চায় তাহলে 8টায়, সন্ধ্যা 8টার দিকে সে খাবে। এটা আমরা যদি লিখে দিই তাহলে আরো স্পেসিফিক হয়।
You're right, because it peaks blood level at 3 hours. So right. If he takes it at 8 and goes to bed at 11, it's a very good tool for him.
রাইট, আমাদের দেশে এটা ফিল ফ্রেশ নামে আছে, যে আমাদের যারা পার্টিসিপেন্টরা আছেন তাদের জন্য বলছি। থ্যাংক ইউ।
Any more input, please? আমরা কিন্তু আমাদের পার্সোনাল রোগীদের কথা শেয়ার করতে পারি, যেটা আমরা অনেক সময় আমাদের অনেক পেশেন্ট আছে যে আমরা we are doing everything, but at the end of the day we fail number of few, but still we will try our protocol, we will try our best. It's not guaranteed that it will always happen, so we shouldn't feel bad, but at least we should try using the sleep diary, just 1 page, giving it to the patient. Please drop it to my practice, and then a suitable time we can go through it.
আসসালামু আলাইকুম স্যার। অনেক সময় দেখা যায় স্যার, অনেকে এই ঘুমের ওষুধ ম্যাক্সিমাম ডোজ নেওয়ার পরে বলে ঘুম হয় না। যেমন রাইবোট্রিল অনেক সময় 2 mg নিলেও নাকি ওর কিছুক্ষণ ঘুম হয়, আবার দেখা যায় যে কিছুক্ষণ পরে ঘন্টা 2 ঘন্টা ঘুম হলো আবার হয়ে যায়। এদেরকে আমরা কি করতে পারি?
প্রথমে we'll explain it, that very basic pharmacology, because they had developed the tolerance, pharmacological tolerance, because unfortunately this kind of medications, we like an opioid as well, that we keep on going, but after some time it doesn't work. Body requires further, because the receptor issues, the metabolism, we need more, and it's never ending. So we'll reach a point, nothing will happen, because the patient has developed the tolerance for these medications. Dependence is a psychological issue, but tolerance is a real physical issue, pharmacological issue. So in that case, we have to explain first thing that, look, this is not working, this is not your fault, this is the body. After a certain time, it will not work even if we increase the dose. So in that case, can we go back again to the basic about underlying issues like any stress, anxiety, any physical problem, and then we can go for the Suboxamine. the newer medications which we are talking. Where is it? Suboxone. I'm talking about this one, Suboxone, Bangladesh jeta, we can find it, Sobutol. We can give a trial with this one. But unfortunately, sleep doesn't work only on only one receptor, or quite a few receptors are in the brain. Yeah, and some of them are still not discovered. Huh? But this is a relatively safer and effective one. We can try safely without developing tolerance or dependency. And we can add as well as some melatonin as well. But again, there could be a synergistic effect. The patient can feel quite drowsy next day. So these are the things. And some people off the shelf, they use like amitriptyline for the pain and the sleep, but not textbook practice, but that might be helpful. And so the patients you're talking about, any physical issue, psychological issue is there or not really? Dr. Divakar?
Yes, sir.
The patient you raised, any other underlying issue, physical issue, psychological issue?
আমরা সাইকোলজিক্যাল তো আছি মোটামুটি সব রোগীরই তো মোটামুটি কিছু না কিছু আছে।
এটা অবশ্য ঠিক, আছে তো।
গ্রামের মানুষ তো বিভিন্ন সমস্যা নিয়ে ভুগে।
সেই ক্ষেত্রে কি আমরা ইয়া করতে পারি আপনার মানে কিছু অন্য মেডিকেশন এসএসআরআই ছাড়াও আপনার মিটাজেপাইন আছে যেটা 15 মিলিগ্রাম দিয়ে শুরু করতে পারি, 30 মিলিগ্রামে যেতে পারি। That can be helpful on both way. It affects the sleep in a nice way and the anxiety as well. No? So that could be a instrument, or that could be a medication, so we can give a trial. Mirtazapine.
Yes.
Which that can help the anxiety or depression and as well as the sleep. No?
Yes. Thank you.
Thank you.
জি, আমাদের পার্টিসিপেন্টদের মধ্যে আর কারো কোনো কোশ্চেন আছে? খুব ইন্টারেস্টিং একটা সাবজেক্ট। আমাদের ডক্টর নাজমুল খুব মেটিকুলাসলি এবং খুব স্টেপ ওয়াইজ কেস বেসড ডিসকাশন করেছেন আপনাদের জন্য। খুবই সুন্দর ডিসকাশন হয়েছে। আমি ডক্টর নাজমুলকে কনগ্রাচুলেট করছি, ধন্যবাদ জানাচ্ছি আসলে এত সুন্দর একটা ক্লাস তৈরি করার জন্য আপনাদের জন্য। আপনাদের আর কারো কোনো কোশ্চেন আছে?
ডক্টর কবির, আমি মেনশন করতে চাই যে অনেক সময় তো ডিফিকাল্ট পেশেন্ট থাকতে পারে, এটা যদি আমাদেরকে ইমেল করা হয় দেন উই ক্যান রেসপন্ড। মানে আমরা কিন্তু আছে না যে রেসপন্ড করবো যে আমার এই ডিফিকাল্ট পেশেন্টটা, দেন উই ক্যান অলসো টক টু দ্য কনসালটেন্ট হিয়ার or we can do the literature search and we can go through. It will be a learning curve for both for me and for our participants and for the patients. So it's not the end. The lecture is not the end. Please feel free to send us your complex patients, complex situation, complex case. We will try our best, because we are the front runner of family physician in Bangladesh. So we'll help each other. And our personal request, another request, please. Like we are not perfect. My presentation, maybe my pronunciation, maybe my content could be much more better. So if we give us a feedback, that will be, I'll be very grateful.
ওকে, অবশ্যই। আমাদের পার্টিসিপেন্টদের মধ্যে ডক্টর নাজমুলের ইমেলটা আছে, আপনারা কেস ডিসকাশন করতে পারেন, ওনার লেকচারটার ফিডব্যাক দিতে পারেন, অবশ্যই আপনারা দিবেন আমি আশা করি। এবং উই আর এক্সট্রিমলি থ্যাঙ্কফুল টু ডক্টর নাজমুল ফর দিস প্রেজেন্টেশন। তো আমি এখানকার যারা জিপিরা আছেন, ডক্টর নাজমুল আপনার পারমিশন নিয়ে 1 মিনিট একটু কথা বলতে চাচ্ছি। এটা হলো যে আমাদের এই যে আমাদের ডক্টর দিবাকর একটা কেস বললো, ভেরি কমন একটা কেস, যে অনেক মেডিসিন খাচ্ছে, ওষুধ চেঞ্জ করছে, আবার হাইস্ট ডোজে চলে যাচ্ছে, তাদের স্লিপ প্রবলেম সলভ হচ্ছে না। তো এখন এখানে আমাদের জিপি হিসেবে কি করা উচিত? ডক্টর নাজমুল কিন্তু বারবার আপনাদেরকে বলছে স্টেপ গুলো, আমাকে কিন্তু প্রথমেই প্রপার হিস্ট্রি, মেটিকুলার হিস্ট্রিতে যেতে হবে। হিস্ট্রিতে আমাকে ফাইন্ড আউট করার চেষ্টা করতে হবে, ইজ ইট প্রাইমারি অর সেকেন্ডারি। সেকেন্ডারি মানে যেটা ডক্টর নাজমুল সুন্দর করে বলার চেষ্টা করছে, কোমরবিড ইনসমনিয়া। আপনারা নিশ্চয়ই খেয়াল করছেন কোমরবিড ইনসমনিয়া, যেটাকে সে বাইডিরেকশনাল বলা হয়েছে। আমি যদি কোনো কোমরবিড ইনসমনিয়া পাই, এই যে কেসটা আপনি বলছেন যে হাইয়েস্ট ডোজে গিয়ে ঘুম হচ্ছে না, অবশ্যই এখানে কোনো একটা প্রবলেম এখানে আছে, যে প্রবলেমটা আপনি এখন হয়তো হালকা করে বলছেন, এটা সাইকোলজিক্যাল হতে পারে, সাইকোলজিক্যালি এত আছেই, বাট নো, এত হালকা করে নেওয়ার কিছু নাই। ইউ ফাইন্ড আউট দ্যাট সাইকোলজিক্যাল প্রবলেম এন্ড ইউ টেক হেল্প ফ্রম দ্য সাইকোলজিস্ট অর সাইকিয়াট্রিস্ট। তাকে কিন্তু আপনাকে একটা সলিউশন দিতে হবে, এবং সেই সলিউশনটা হবে যে যদি সেকেন্ডারি কজ হয় তার একটা কজ বেসড ট্রিটমেন্ট দিতে হবে। আর যদি প্রাইমারি হয়, আমি আবার একটু ডক্টর নাজমুলের কথা বলে আমি এবার রিপিট করছি, যেরকম উনি বারবার বলছেন স্লিপ হাইজিন ভেরি ইম্পর্টেন্ট একটা ইস্যু এখানের মধ্যে, ভেরি 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 ইম্পর্টেন্ট একটা ইস্যু ফর জিপি। স্লিপ হাইজিন এখন এখানে ডিটেলস কথা আমি বলতে চাচ্ছি না, আপনারা সবার হাতে ইন্টারনেট আছে, সবার হাতে আছে, আপনারা জাস্ট একটা সার্চ দেন স্লিপ হাইজিন, ইউ উইল গেট ইলাবোরেট থিংস দেয়ার, হাউ ইউ উইল ইমপ্লিমেন্ট their sleep hygiene, how you will maintain their sleep hygiene. এটার সাথে উনি আরো কিছু কথা বলছেন যে রেস্ট্রিকশন টাইম, ওই যে টাইম সেটেলড করা, মেনটেন করা, ওয়াক আপ এবং স্লিপে যাওয়ার এবং কিছু বিহেভিয়ারাল ইন্টারভেনশনের কথা বলছে। এর মধ্যে কিন্তু আমাদের চা ক্যাফিন খাওয়ার অভ্যাস কিরকম, এই প্রত্যেকটা জিনিস আপনি ওই যে ডায়েরিটার মধ্যে যতগুলো কোশ্চেন আছে প্রত্যেকটা জিনিসকে আপনাকে ইলাবোরেটলি দেখতে হবে, সেখান থেকে বের করে আনতে হবে আসলে প্রবলেমটা তার কোথায়, এবং তাকে সেইভাবে হেল্প করতে হবে, গাইড করতে হবে। আমি আশা করি এই প্রবলেম গুলো যদি আমরা একটু সুন্দর করে দেখি, আজকের এই ক্লাসের মাধ্যমে আমরা অ্যাটলিস্ট একটা সুন্দর গাইড পেয়েছি, যে গাইডের মাধ্যমে আমরা কিভাবে হিস্ট্রি নেব, কিভাবে তার স্লিপের ডায়েরিটা আমরা রাখবো, রেখে তাকে আরো ইলাবোরেট হিস্ট্রিটা বের করতে পারবো, এবং কোন রকমের সেকেন্ডারি কজ কি আমরা পাচ্ছি কিনা, কোমরবিড কজ পাচ্ছি কিনা, সেই কজগুলোর উপর আমি কি ক্যাপেবল কিনা আমি সেই চিকিৎসাটা দিতে। আমি যদি ক্যাপেবল না হয় আমি একজন স্পেশালিস্টের হেল্প নেব, এবং অবশ্যই আমরা পেশেন্টকে হেল্প করতে পারবো। ইনসোমনিয়া শুধু ঘুম হচ্ছে না আর আমি তাকে শুধু বেনজোডায়াজিপামের উপর চলে যাব, বা আমরা যেসব মেডিসিন কথা চিন্তা করছি সেগুলোর উপর চলে যাব, নো, আমরা ওইভাবে সরাসরি যাব না। আমরা জিপি, আমরা ট্রেন জিপি, আমরা ফ্যামিলি ডক্টর হতে যাচ্ছি, আমরা ফ্যামিলি ফিজিশিয়ান হতে যাচ্ছি। আমাদের অ্যাপ্রোচ অবশ্যই একটু মেটিকুলাস হবে, আমাদের অ্যাপ্রোচ অবশ্যই একটু পেশেন্ট ফ্রেন্ডলি হবে, পেশেন্ট সেন্টার্ড হবে। এবং সে যে কথাগুলা ডক্টর নাজমুল সুন্দর করে আমাদেরকে বলেছে, কি বলেছে, বায়ো, সাইকো, সোশ্যাল, এই তিনটা শব্দ দিয়ে খুবই সুন্দরভাবে উনি আমাদের ফ্যামিলি ডক্টরদের কন্ট্রিবিউশন, আমাদের ফ্যামিলি ডক্টরদের অ্যাপ্রোচ টু এনি পেশেন্ট, এটা বলেছে, বুঝিয়েছে আপনাদেরকে। আমি আশা করি আপনারা সেটা বুঝতে পেরেছেন এবং সেইভাবে আপনারা কাজ করবেন, এবং অবশ্যই আপনারা ইনসোমনিয়ার পেশেন্টদেরকে সহযোগিতা করতে পারবেন, হেল্প করতে পারবেন। আর এই যে ডক্টর দিবাকরের মতো অসহায়ের মতো সারেন্ডার করার কিছু নাই, যে এরকম হয়ে গেছে আর কি করব, আর কিছু করতে পারবো না, নো, আমাদেরকে তাদেরকে সহযোগিতা করার অনেক স্কোপ আছে। থ্যাংক ইউ ভেরি মাচ। যদি কারো আর কোনো প্রশ্ন না থাকে আমরা কি শেষ করবো, ডক্টর নাজমুল?
আসসালামু আলাইকুম স্যার, আমি নজরুল। স্যার একটা জিনিস জানতে চাচ্ছি যে আমাদের কাছে তো অনেক সিওপিডি পেশেন্ট আসে, তো এদের অনেকেরই মানে ঘুম হয় না, এদের জন্য কোনটা সেফ হবে, মানে কোন সিডেটিভ দেওয়া যাবে কিনা, বা কোনটা সেফ হবে, নাকি অ্যান্টিহিস্টামিন জাতীয় দিতে হবে?
সিডেটিভ সিওপিডিতে রিয়েল লাইফে যেটা আমরা যে দেখি আর কি, যে আপনার টেক্সট বুকে বলে যে we can't give benzodiazepine because that can suppress the respiratory center and can cause a disaster. But আমি এটা অ্যাডভোকেট করবো না, কিন্তু আমার পার্সোনাল লাইফ এন্ড এক্সপিরিয়েন্সে অ্যারাউন্ড মাই প্র্যাকটিস, we can give, but we definitely, it is not a textbook advice, but on real life, it's not like this patient will go into respiratory failure or arrest. No.
Thank you.
Yeah.
আর কারো কিছু আছে, বলবেন কিছু? আচ্ছা, ঠিক আছে, যদি কারো কোনো আর কোশ্চেন না থাকে, আমাদের পক্ষ থেকে, সকলের পক্ষ থেকে ডক্টর নাজমুলকে আবার থ্যাঙ্কস জানাচ্ছি, এবং আমরা আশা করব ভবিষ্যতে আমাদের সাথে ডক্টর নাজমুল থাকবেন, এবং আমাদের পক্ষ থেকে আমি সবসময় আমাদের এক্সপেট্রিয়েট ডাক্তার যারা আছেন, ডক্টর নাজমুল সহ ডক্টর সুব্রত আমাদের সাথে সবসময় আছেন, তাদেরকে আমি সবসময় অ্যাপ্রিসিয়েট করি তাদের কাজের জন্য। আবার আপনাদেরকে ধন্যবাদ জানিয়ে তাহলে আমরা শেষ করছি আজকের মতো। জি, আসসালামু আলাইকুম।
সবাই ভালো থাকুন, সুস্থ থাকুন।
থ্যাংক ইউ স্যার, আসসালামু আলাইকুম।
ওয়ালাইকুম আসসালাম।